All right. Can everybody see this presentation? Nod if
Yes.
you can. Okay, perfect. All right. Well, thank you for the introduction. I'm Humberto Virrallear. I'm one of the urologists at the City of Hope Cancer Center. Not everybody knows this, but we don't just treat cancer patients, though that's our singular mission. We also have community practices in support of Pasadena, Glendora, and then of course some of us will support the City of Hope campus in Duarte. But we do treat benign conditions as well. In fact, that's actually my specialty is in reconstructive urology, reconstructive surgery, and men's health. These views are my own. I do not have any financial conflicts of interest related to the subject matter. A little bit about me. Like I said, I recently joined the group. I started in 2021 in December. Prior to that, I was at Loma Linda University, just down the road. And I, even though I'm not a cancer surgeon, I am in charge of the cancer survivorship program. So that's dealing with the after effects of many of the cancers that we see at City of Hope, but mostly focused around prostate cancer and bladder cancer survivorship. There's a list of the conditions that I treat. I mainly see men, but I do also see women with complex urologic issues. And then we also have one of my partners that is subspecialty specialized in the treatment of female pelvic medicine conditions as well. His name is Seth Cohen. A little bit about the goals of this talk. So initially, when we discussed topics, we generally discussed kind of a review of prostate or bladder conditions. As I said earlier, before some of you got on the talk, not everybody that is here has a prostate, but they may love somebody that does have one. So there's a little bit of here for everyone, and this is just a framework for discussion. We can shift to generally discussing urinary symptoms, overactive bladder, medications for urinary function as the group sees fit. But I do want to talk about the evaluation and management of some of these conditions, review medical therapy for enlarged prostate. There's a whole section on surgical treatment for benign prostatic hyperplasia or enlarged prostate, and then something about what we see now in the future of treating this condition. So just to review some relevant anatomy here in this picture, we see on the left side this is the bladder as it funnels down into the prostate. So the prostate's a gland that is found in men. It has several functions, but mainly creates and distributes certain secretions that are important for ejaculation and sexual function. Additionally, the prostate in some men can become enlarged as we age, and that's why it's important to understand kind of the lay of the land. What we mean by you have an enlarged prostate. When you go to your physician, they tell you that you potentially could have a growing problem. The urethra itself courses through the center of the prostate gland, as you see here. And then here is kind of a cross section of how it all appears. And depending on family history or dietary issues, some of these zones in the prostate can overgrow and cause impingement or cinching down on the urethra. And that's what's affected. That's what we aim to treat medically and or surgically whenever is indicated. So hyperplasia of the prostate just means that there's an increased number in the prostatic cells, particularly for benign reasons in the transition zone of the prostate, so closer to the middle. Hypertrophy refers to overgrowth of individual size cells. And when you go to the doctor and you have urinary complaints or urinary symptoms, we want to capture really what the problem may be. You may be coming to the doctor with one specific set of concerns in mind, but then as we start pulling at the medical history, we may identify several contributing factors or conditions. Certainly, when you go to the doctor, we want to talk about some of the other medical problems that can contribute to your urinary symptoms independent of the prostate and or the bladder. So Do you have diabetes? How well is the diabetes controlled? Do you have elevated blood pressure or heart failure? And are you on medications to control those conditions like diuretics? The water pills can certainly make urinary symptoms worse. What kind of surgeries have you had? Have you had surgeries of the urinary tract or the pelvic organs or the female reproductive organs in women? Does that contribute to your overall urinary health? Do you have any surgical implants? Those are all things that we tease out as part of the initial evaluation. What is our diet like? So the common American diet is not generally very healthy, and in fact, an overabundance of processed foods and certain foods can be very irritating to the urinary tract. So we try to tease that out. If you go to the doctor and you're talking about peeing every hour on the hour, but you're walking around with a coffee tumbler, the size of my head, then that's probably contributing to your urinary issues as well. How physically active is important. Being more physically active improves your health overall. But patients that have impaired mobility may have trouble springing up and getting to the bathroom when they feel like there's a need to go. So consequently, there may be an issue with leakage of urine. You don't quite make it there, or by the time that you do make it there, you've already started leaking urine. So it's important to note, is there a functional component as well? And then other pertinent positives, tobacco use, recreational drug use, alcohol intake. All these conditions are potentially modifiable. So the first step is to target the things that we can do less of or increase more of for the benefit of the urinary function. So when I see patients for evaluation of urinary symptoms, we try to give validated questionnaires so that we can be consistent in what we're addressing. Certainly like to get a baseline assessment and ask several important questions prior to starting therapy, but then in follow-up of a certain medication or combination of medications, and definitely in follow-up of a potential procedure or surgery to treat the urinary condition. So things that men commonly complain about when they come to the doctor to address their enlarged prostate, there are two different domains of symptoms. They're the blockage type symptoms or flow related symptoms, and they are the urinary frequency and urgency type symptoms. And those are treated very differently eventually, but at first we kind of have a general approach of treating everybody with the same medication. So we asked, if there are any difficulties with bladder emptying, issues with urinary frequency, going back within 2 hours of the last time you urinated, intermittency, meaning starting or stopping of urination, urinary urgency, once again, is that have to go sensation, weak straining to urinate, and then going at night. How frequently do you get up in the middle of the night to urinate? And I tell patients, out of all the symptoms that I can treat with a pill or a procedure or a surgery, the going at night is the least likely to be exclusively related to your prostate or your bladder. Certainly in men and women, they can all have difficulty going at night. So if the going at night is the primary issue, there may be other conditions that are contributing, like sleep apnea is the number one condition. So if you snore at night, or your partner snores at night, or if you get an elbow jab in the middle of the night, then that could be why you're having difficulty with going frequently at night. So you may benefit from a sleep study from a qualified sleep specialist. So then, based on the questionnaire responses, we add up all the responses and give you a score and grade the severity of symptoms based on the total score of what bothers you. So like I alluded to earlier, at least in men, when men develop urinary symptoms, and it's typically as men age, we treat everybody the same. We give everybody medications that aim to relax the prostate so that it can make urination more efficient. The prostate is a gland, but it's interwoven by smooth muscle. So medications that relax the prostate make it so that instead of urinating through this much resistance, you're urinating through less resistance, a wider, less narrow channel. Certainly, as the prostate overgrows, it can compress the urethra internally, as I showed you during that cross-sectional picture. And as I alluded to earlier, it is a growing problem that increases with age, in that, enlarged prostate, or BPH, affects 70% of men aged 60 to 69, and 80% of older men. And that's based on several epidemiologic studies that have been performed. I already discussed the symptom score, where you grade your symptoms. And then once you come to a specialist, if you weren't already on medical therapy, and your primary care physician can initially initiate the first-line medical therapy for enlarged prostate, then by the time you come see a specialist, you may be started on a medication, or depending on some of your other medical conditions or surgical histories, you may benefit from additional testing to include urine tests, a flow rate where we have you pee in a machine that measures the speed at which you urinate, and even doing a little bladder ultrasound in the office to see whether or not you're emptying your bladder. And these evaluations also apply to women. So when women have similar urinary symptoms, we pretty much undertake a similar evaluation. There are other tests that are more invasive, and we only undertake those if indicated, or really if you're planning on pursuing a procedure or a surgery to treat your urinary condition, and it can help us sort out some of those details as well. So those are procedures like looking inside with a camera or scope, cystoscopy, or urodynamic studies, which is kind of a complicated infusion test where there's fluid put into your bladder, and it measures how your bladder reacts to being filled with fluid. Any questions from the group so far? Let me look at the chat here. If you have questions, you can type them in the chat, and I can look those up. Okay, so I'll keep an eye on the chat as we go along. So in terms of treatment for enlarged prostate, behavioral things like, and this applies also to overactive bladder in women and in men, because both women and men can have overactive bladder. We initially aim to modify behaviors such as excessive caffeine intake. Cutting down on the amount of caffeinated beverages can improve the frequency and urgency with which you urinate. Also, if you drink carbonated beverages, those can be irritating to the urinary tract as well. So drinking fewer sodas can make a difference in terms of how frequently and how urgently you're going to the bathroom. Additionally, caffeine is a diuretic, so you're going to be making excess amounts of urine the more you consume a caffeinated beverage. And once we get past the behavioral adjustments, then there are herbal treatments that are out there, and medical therapies that we talk about. So additionally, beyond modifying the specific types of foods and drinks that we take in, we also recommend other behavioral interventions. Like if going in night is a big problem, I recommend that people double void at night. So usually urinate an hour prior to bedtime, and then immediately before bedtime, so you're going to sleep with an empty tank. Okay. And then, in folks with severe problems with nighttime urination, I even tell them to just completely restrict fluids at night, stopping with dinner and really nothing thereafter, unless it's, a sip or two to take medication. And I promise you, you're not going to shrivel up into a prune because you stopped drinking after dinner. Herbal treatments are popular. You get them in your mail outs or in your magazines, and a lot of men are on saw palmetto and this, that, and the other, or there's marketing for super beta prostate that you see on TV. But the reality is that these types of medications have very little regulation. They're classified as foods by the U.S. Food and Drug Administration. So they're not well regulated, and they can still cause pretty significant interactions with some of the other medications that patients may be taking, and it can be a big deal if you're on a blood thinner as well. So there's really no convincing data to support herbal treatment, at least for prostate purposes or really any urinary purposes. So then we get into kind of conventional medications that are out there. There's a whole laundry list of options that are available for urinary symptoms. This is specifically for enlarged prostate, but there is some crossover with the treatment of overactive bladder in men and women, and I'll talk about that as well. So the initial go-to are medications called alpha blockers. They act by relaxing the muscle at the bladder neck, where the bladder funnels down into the prostate, and then the actual smooth muscle that's in the prostate itself. So it makes urination more efficient. And I also use alpha blockers in women that have urinary dysfunction to relax their bladder to allow the urine to come down. So the whole goal here is more efficient voiding, less restriction. There's a bunch of alpha blockers out there on the market. You'll recognize them because they end in SIN. The most commonly prescribed one is tamsulosin or Flomax, and there are a lot of men that are on it as they age. Some of the other ones are older type medications that are less selective and are more likely to cause significant side effects. But we know that taking medications such as alpha blockers generally leads to improvement in the symptom score, so reduction in the severity of symptoms, and improvements in parameters like the urinary flow and the urinary emptying. The most common side effects with these medications, it can be dizziness. So usually dizziness from when you get up from a sitting position, called orthostasis, and that's because your blood vessels also have smooth muscles. So if you're taking a smooth muscle blocker, then it reduces the tone of your blood vessels. Okay, and then in men, it's also been shown to lead to ejaculatory dysfunction, problems with ejaculation. And then for folks that are going to be having, cataract surgery later, there is an association between the use of alpha blockers and what we call intraoperative floppy iris syndrome. So if you take one of these medications and you're going to be having eye surgery, in particular cataracts, you should talk to your ophthalmologist about the timing of cessation of the medication. The other type of medications that works on the prostate are medications that actually do shrink the prostate over time. And these medications can take several months to kick in, and they work by blocking the conversion of testosterone to its active form. And that's what causes overgrowth of the prostate. So these medications are called 5-alpha reductase inhibitors. And like I said, it may be months before they really kick in, but some patients truly benefit from them if their goal is to avoid any procedure or surgery to treat their condition. So these medications are very effective. It's been verified on multiple studies that have been done. And we know, as a matter of fact, that combination therapy of alpha blockers and then these other types of medications, 5-alpha reductase inhibitors, have been shown to lead to decreased progression of enlarged prostate symptoms, decreased complications of enlarged prostate, such as urinary retention, not being able to pee altogether, urinary tract infections, and even urinary incontinence. Any questions so far? No, I don't see. Chat's empty. So this next set of medications apply to both men and women in terms of the urinary symptoms. So not every man that has urinary symptoms has pure enlarged prostate. There can be some overlap between enlarged prostate and overactive bladder. And then certainly women are at higher risk of having overactive bladder type symptoms. What symptoms are overactive bladder symptoms? We're talking about situations or symptoms like urinary frequency, urgency, that have to go sensation, double voiding, meaning that you go to the bathroom and then you leave the bathroom, and then within a couple of minutes you're already going back because you feel like you got to go again. And then certainly urgency, incontinence, the leakage of urine from a sudden urge to go to the bathroom. So The way that we treat those symptoms is by decreasing or blocking the impulses or signals from the nerves to the bladder. So these initial medications, the anticholinergics, they're effective in reducing those signals to the bladder muscle to inhibit the bladder muscle contractions. Let's see here. All right. Let's see. Can bladder spasms also be accompanied by bowel spasms? Yes, there's quite a bit of overlap actually between the bladder and the bowel. So as the bowels go, so can the bladder. If somebody has IBS or inflammatory bowel, syndrome, or Crohn's, or any bowel condition, you can perceive those impulses or sensations in the bladder. If you're severely constipated or at risk for constipation, it can affect how you empty your bladder, number one, but also how frequently you're going to the bathroom, because the rectum sits right behind the bladder and it pushes the bladder forward if it's over distended with stool. And I will take some time to comment on the Urolift device as we move along during the presentation. So medications like anticholinergics for overactive bladder, the most common side effects: dry mouth, constipation, which is common as folks age, and blurry vision, which is bad. So, and then in older folks, the one that concerns me the most is confusion. So if somebody's already on medications for confusion, early onset dementia, etc., it's not my preferred treatment to treat overactive bladder with anticholinergics. So there are some more selective ones that are less likely to cause some of these effects. Let's see here. We can also use medications like Viagra, Cialis, Levitra to treat some urinary symptoms. The one that's indicated for urinary symptom is daily Cialis at 5 milligrams. And the more common side effects: headaches, upset stomach, flushing. This newer line of medications, beta-3 agonists, they work differently than the other overactive bladder medications. They still control the impulses, but in a different way, and thereby they have fewer of those concerning side effects. So still the goal is to reduce the frequency and the urgency of urination, but perhaps in a cleaner fashion. Though this medication mirabegron can lead to increased blood pressure in some patients, and then there's a newer medication available that is less likely to do so. But I prescribe these medications all the time in both men and women for overactive bladder type symptoms. But overall, medical therapy can be very expensive over time, and so as you choose to have a continue course of treatment, you have to kind of add up the cumulative cost of paying for certain medications. Some of them are well covered by Medicare or private insurers, others are not. And then certainly this is the case for the overactive bladder medications in men and women. Mirabegron can be quite expensive. So if you're looking at the next 5 to 10 to 20 years of paying for overactive bladder medication versus the upfront cost or risk of a procedure or a surgery for urinary symptoms, these are reasons to consider procedural interventions rather than continuing with all these medications when some patients may already be taking multiple medications for their other medical conditions. So let's move along here. Let's see. Any other questions regarding medications for urinary symptoms?
I also wanted to just add that if you want to send a message in chat directly to Dr. Virrallear, you just need to pick his name in the download thing that shows everybody's names. You don't have to send it to everyone.
Okay.
To let you know.
All right. Anybody else? We're kind of at a natural transition here between medical therapy and surgical therapy. So I'll talk a little bit about surgical therapy for, once again, focusing on the enlarged prostate, but then we can talk about surgical therapies for overactive bladder since we have a mixed crowd. So surgical therapy for enlarged prostate, for a long time there, it was the most common type of surgical treatment that we did as urologists, probably before, even before I started my training. The transurethral resection of the prostate was one of the most common surgeries that we did as urologists. Once again, the relevant anatomy, the goal of surgical therapy is to, for lack of a better comparison, core the prostate out. I liken it to taking a melon baller to the prostate, leaving the rind in place, but scraping all that scraping or vaporizing all that fleshy fruit out. Okay. And there are multiple options for this. For years and years and years, like I said, the gold standard for treatment was the transurethral resection of the prostate, or the TURP, affectionately called the Roto-Rooter in some circles. It doesn't sound very pleasant to me, but that's what I learned to do, and we've been doing that with success for a long time. But the beauty about technology is that as we continue to make new discoveries, then our instruments can get smaller and smaller, and our treatments can become more and more straightforward to recover from. So while TURPs are very commonly done still, there are some other options that are available nowadays. According to our professional society, the American Urologic Association, there are a couple of pretty absolute indications to consider a procedure or a treatment for enlarged prostate. Number one, acute urinary retention. That means you end up in your doctor's office or in the emergency department in the middle of the night not being able to pee, and you get a catheter placed. And anybody that's had a catheter placed knows that it's not a comfortable thing to have. So most of the time, patients are knocking down our doors to see what we can do about taking the catheter out. When urine sits around over time, it can layer and collect into stones. So having bladder stones is a indication to have some sort of prostate treatment. Azotemia or impaired kidney function. So that means you're holding onto urine over time and it can damage your kidneys. That's a reason to consider a treatment. Recurrent urinary tract infections or blood in the urine. And then of course, worsening symptoms that don't respond to medical therapy. So, the goal of the TURP, which is what's been around for a long time, is to scrape the excess tissue out. And it can be quite effective, and patients can notice a significant improvement even as early as 3 months out from surgery. Though not everybody will have a similar improvement, and these men will be shown to have some sort of other urinary dysfunction. Before I even started my training, like I said, even before medications were commonly available, this is the most common surgery. So all men with urinary symptoms got treated the same. Everybody got a TURP, right? And some men either did beautifully and they peed like they did when they were a young lad, or they didn't. And the men that didn't, we couldn't really figure out why. Well, our diagnostics have gotten better. This is where urodynamics come into play. And these studies can help us sort out, who really has a prostate problem, a blockage problem, versus who has some sort of bladder dysfunction as a result of other medical conditions or surgical conditions that are confounding. We can also do TURP with lasers. So instead of scraping the tissue out with an electrical current, we can take a laser to the prostate and sort of melt or vaporize the overgrown tissue. I think it's a good option in a lot of men. There's some purported advantages, though I think it's very operator dependent. I say, I used to teach residents, and I emphasize it's not the tool, it's the tool behind the tool that makes a difference. So laser prostatectomy is still around. It can be useful in certain patients. It's actually quite useful in patients that have enlarged prostates, and that are on blood thinners, because sometimes you don't need to stop the blood thinner to do this type of prostate surgery. And there are different lasers that we can use. The green light laser is the one that melts the overgrown tissue. There are some other lasers that we use to help with the coring of the inside of the prostate, balling it out like balling a melon. And those are thulium lasers and holmium lasers. But I think the advantage of these treatments is that they're minimally invasive. They're done transurethral, so with a scope in the urethra, no cuts, no incisions to heal from, and the recovery can be very straightforward in the right patient that's well counseled. So I'll just skip a couple of slides here. It's more about specific lasers. One of the downsides to the laser is that it can lead to some pretty severe worsening of urinary symptoms as the prostate heals and remodels. So some patients can have pretty severe burning with urination after laser prostatectomy. So for that reason, it's not my favorite, surgical treatment for enlarged prostate because I feel like patients can be pretty miserable. But I still think it's a good option. My father-in-law had it done, and he's pretty happy with it. However, the minimally invasive and the simple recovery type procedures, they're only an option if the prostate is small enough to treat with that. Otherwise, tackling a big prostate with a minimally invasive treatment would take hours and hours and hours and may not be efficient and or safe to the patients. So for bigger prostates, sometimes the most direct route is to remove most of the prostate tissue surgically. When I first started training, the most common way to do this was to actually cut into the bladder or into the shell of the prostate, if you will, and scoop the prostate tissue out. And that's called a simple prostatectomy. And it used to be kind of a grotesque, bloody surgery because the prostate is a very vascular organ. But now, as technology improves, the most common way that we do this is in a minimally invasive fashion using robotic assisted surgery. So we use laparoscopy to cut the excess tissue and then put the good tissue back in place and to help with the recovery. So it's actually a very much more elegant surgery nowadays compared to what it used to be. But because the prostate's a very vascular organ, of the potential complications, acute blood loss, the need for a blood transfusion, other complications such as narrowing of the bladder neck or contracture of the bladder neck, and or urethral stricture, so narrowing of the urethra, which is what I specialize in treating both of these conditions, bladder neck contractures and urethral strictures. It also means that you may stick around the hospital a little bit longer if you have a simple prostatectomy compared to some of the other less invasive surgeries. So you have a question in the chat. What are Kegel exercises for women, and are these exercises, are there equivalent exercises for men to improve control? Excellent question. So, Kegel exercises in women and in men, the goal of these exercises are to reduce urinary leakage, generally from stress incontinence. That means coughing, bending, sneezing, positional changes. So the goal of Kegel exercises are to strengthen the pelvic floor to allow more, more obstruction to keep you from leaking from a change in position or activity. So in women, the most common reason why women experience stress urinary incontinence is as women age in general, there can be positional changes in the pelvic organs, or as a result of pregnancy, the urethra and the bladder, that their layout relative to the pelvic structures will change. So they lose support, and consequently there's less holding back the urine. So women benefit from Kegel exercises as an initial treatment or an initial approach of dealing with stress incontinence. Men will need to do Kegel exercises if they have incontinence after a treatment of their prostate, whether it's a prostatectomy for prostate cancer or a prostatectomy for enlarged prostate, like a simple prostatectomy. And I tell everybody, Kegels are like, they're squeezing, relaxing exercises of that sphincter muscle that you would squeeze to hold your urine back voluntarily. And I tell people doing Kegels is like going to the gym. You go to the gym consistently on a routine with a specific goal in mind. You don't just go to the gym because you have trouble picking up a box at home and you feel weak. Same with Kegels. You try to do them consistently, do a set amount. I tell people, do them when you're wasting time. Like if you're driving around town at a traffic light, every traffic light, you should do a couple of squeezing, relaxing exercises to help with the urinary control. Let's see here. So then there are other minimally invasive treatments for enlarged prostate. Some of these are historic, and then there are some newer ones that are out there that to include the Urolift that somebody was interested in. But the TUNA is a historic procedure, though there are still some older urologists in the community that are doing it, and it's putting a scope in the urethra and then putting a needle into the prostate and using radio frequency to cause the prostate gland to shrivel up. It looks rather rough to me. I think of it as like a snake biting the inside of your prostate. That's what it looks like, these fangs that shoot into the prostate tissue. And frankly, it's not super common anymore. But once upon a time, before technology got better, it was effective in some men. I think the common theme for all of these treatments that I'm mentioning is you have to be the right patient for the right procedure. And if there's ever any doubt, don't be afraid to get a second opinion. Same goes for microwave therapy of the prostate. It's almost never done now. It uses microwave energy to cause, involution of the prostate tissue. I don't think I've seen a microwave therapy in the last 10 years. So mainly here for historic purposes. But some of the new kids on the block that are more promising are the newer, what we call missed procedures or minimally invasive surgical therapies. The goal of some of these is to do them in the office with you either awake or under sedation. There are a couple of benefits to that. Number one, it's cheaper for you and your insurer to get this done on an outpatient basis in the clinic. But also it avoids the stress or strain of general anesthesia. It keeps folks out of the hospital, and that's important now in times of COVID. You want to avoid hospitals if at all possible. The prostatic urethral lift or Urolift is an implantable device that's used in certain men with enlarged prostates. Now, of all the treatments that I'm going to mention, this is the one prime example of being the right patient for the right treatment. This is one of the treatments that unfortunately gets very inappropriately used in some men. When you go to a specialist and they only offer certain options, you may not get completely counseled regarding all the options that are on the table. So some men may be treated with the Urolift when in fact they may have been a better candidate for prostate enucleation or simple prostatectomy. But in the right men, it can be a very effective treatment. The way that it works is we look inside with a scope, and when you look inside and see the prostate, you see the walls of the prostate kind of collapsing into view. So what the Urolift does is it helps us clip the tissue to the side, kind of like we're drawing the curtains and clipping them to the side. So it does widen the urinary channel, but it doesn't get rid of any actual tissue. And if you're a guy that has a very, very large prostate, I think the Urolift may be just a Band-Aid, and you could eventually need something more definitive for your prostate. I don't know if that answered the Urolift question. Similar to the Urolift, one of the other new kids on the block is the Resume therapy, which is meant to be an office-based treatment as well. Both of these treatments have the obvious discomfort of a scope being in your urethra with you awake. Though in certain centers, we can put you to sleep or do sedation for the Urolift. Some centers, we can do that for Resume. It depends where the machine that does the surgery lies. With the Resume, very similar to the Urolift, it's been championed as a quicker recovery, more straightforward option that should not require you to go under general anesthesia. Here we also insert a scope, and very similar to the TUNA procedure, we fire a needle into the meat of the prostate, but instead of radiofrequency energy, we use steam injections to get the prostate tissue to shrivel up over time. So we deliver hot steam into the prostate, and then the prostate tissue will shrivel up over the course of several months. As you can imagine, steam or heat energy going into your prostate could be painful. So we do local anesthetic injections, as well as some offices even have a platform by which you inhale nitrous oxide gas for sedation and or kind of reduction of anxiety. So I'm currently working with City of Hope to get that for our office to make office-based treatment for enlarged prostate more feasible for patients that want it. And then there's a newer device called the iTind, which is, it's even newer than all of these other ones. And the way that it works is it's a temporary implant into the prostate itself. So it's like a placeholder or a cage that expands inside the prostate and pushes the prostate tissue aside, and it stays for 5 to 7 days and causes some remodeling of the prostate tissue from the inside out, almost like placing a scaffold in the prostate. Then after it's been in for 5 to 7 days, you come back to the office and we remove it, and it's been shown to lead to some improvement in symptoms. So that takes care of surgical treatments for the prostate. Now, I talked about medical treatment for overactive bladder during our medical discussion, but even in spite of medicine, some of those symptoms will persist with time. So then we get into like second line treatments and third line treatments. So we're talking about procedural or surgical interventions for the frequency urgency type symptoms. So or maybe it's that you have bothersome symptoms, but you can't take certain medications because of the associated side effects. So for men and women, there are options to treat frequency and urgency and leakage due to urgency by doing bladder Botox injections. So same Botox toxin that the celebrities will use for their face, we can deliver that in the bladder to block or reduce the impulses, to the bladder to control the frequency and urgency symptoms. So it does require either outpatient surgery or a procedure done in the clinic to deliver the medication by direct injection into the muscle of the bladder. But that's an option for men and women with overactive bladder. And then there are other options surgically for overactive bladder by which we retrain or reset the impulses to the prostate by stimulating the nerves with an electrical current, much like a pacemaker for the bladder. And that's also a surgical implant that's available called an InterStim device. So there are options. I think the most important thing to learn from this talk is fix what you can fix at home. Talk to your doctor and scrub your medication list and make sure that all the medications that you're currently taking are appropriate for your current condition. Sometimes things just kind of get added on and pass over time. And then you can start treatment for your urinary symptoms with your primary care doctor. But if they're not comfortable or they think you have a complicated condition, then you should seek evaluation from a specialist, and we're happy to see you at any of the City of Hope practices. So I'll open it up for questions here.
If you want to unshare, Dr. Virrallear, we can
Yes,
all
give me 1 second.
assume our former sizes.
Yeah. Sorry. There it is. All right.
Okay, people, just unmute yourselves and ask your questions or make your comments. I can see a lot of perplexed people. the women especially. Oh, this is all about the prostate. I don't have one. Except for Esther. Where's Esther? Oh, she left. Oh, there she is. Esther and Bruce, the only couple. Well, I did want to make the comment about caffeine. I find that I didn't realize how even 1 cup of coffee can lead to, increased overactiveness. And I find that if I'm going somewhere where I don't want to be bothered by overactive bladder, I just don't drink any caffeine and I'm fine.
Yeah, definitely. And not only that, but also the caffeinated teas.
Yeah, and then sodas, the carbonated drinks, most of them have caffeine in them. So
exactly.
And is there any other comment or question?
Guess not.
Gee, we were just all sponges absorbing all the information and knowledge. Nobody had any questions. And I realize it's kind of a, embarrassing topic. And most people don't want to use their real life examples unless they consult with somebody in private. But
you can always ask me about your friend that has a problem as well.
That age-old excuse.
Yeah.
I would like to know, what is the relationship between sleep apnea and night frequency?
That is an excellent question. It's one of my favorite questions to answer because people have a hard time accepting that. The issue with sleep apnea is a couple of situations. So number one, anything that disrupts your sleep will make you aware of your bladder fullness at night. So whether it's your sleep apnea or your creaky door out on the porch, or like in my case, my daughter running into the room in the middle of the night, if I'm woken up, I'm going to realize that my bladder is a little bit full and I'm going to take myself to the toilet and go to the bathroom. But specific to sleep apnea, there's a physiologic reason why it leads to frequent urination at night. So if you have sleep apnea, it's causing blockage of your airway. And if you have blockage of the airway, it leads to elevated pressures in your lungs. And then that transmits to your heart. So it leads to elevated pressures in your heart, and specifically in the smaller chambers, the atrium. So if you have elevated pressures there, then your heart actually secretes a hormone that causes diuresis. So it's like taking a water pill, if you will. So there's like atrionatriuretic peptide, which is a hormone that causes you to secrete excess amounts of urine at night. Same with the other condition that can lead to nighttime frequency that's unrelated to the bladder or prostate is swelling of the lower extremities. So if you have vein disease, circulation problems, if your legs swell up at the end of the day, when you take your legs, take the stress off your legs and lay down to sleep, all of that fluid that's in the legs is going to sneak back into circulation. So then all of this new fluid is out in the circulation. It's like you drink a cup or two of water in terms of the overall effect that it has on your body.
Okay, thank you.
You're welcome.
Next. You look like you have a question, Bruce. No.
I see a lot of note taking and or doodling.
Oh, you're muted, so I can't hear you.
Not at this moment.
No.
Not at this moment.
Okay, well, it's not going to do any good if you think of it afterwards. Okay, well, I think that probably concludes our presentation then. I'm sorry if I didn't realize that there would be more women here than men.
Well,
although men are a minority in the village, I was kind of hoping there would be more male interest, but.
Well, we have plenty of topics that we can cover for future talks if you will have us back. like I said, Dr. Seth Cohen is one of my partners. He's our specialist in female pelvic medicine. And, you know, if maybe for next time, there are other topics that we could discuss.
Okay, great. Well, thank you very much, Dr. Virrallear. This has been very not entertaining so much as instructive.
Well, I aim to do both, but sometimes I fail at one. So thank you for having me and enjoy the rest of your day.
Okay, thank you. Bye-bye. Okay, so now I'm going to stop recording. And